In a massive 53-page treatment guideline on complex regional pain syndrome, or CRPS, the authors state that occupational therapists are the ideal therapeutic leaders in the functional restoration process. And they go on to devote 2 pages to what this OT care can entail. In today's episode, we'll pull out important implications for OT practice from the entire guideline. And you'll see when it comes to treating chronic pain like CRPS, there is a lot of best practices to draw on, but also a lot of unknowns that necessitate close attention to the individual in front of you. To help us flesh out what all the information in this guideline means for OT practice, we are so excited to welcome to the podcast Megan Doyle, a program manager at an outpatient pain program and a leading voice on OT's role in pain management. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this big topic of OT and CRPS, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. So bearing in mind that this could count as a CEU course, I wanted to state our 2 learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is that you will be able to recognize recommended assessments for CRPS that OTs can utilize. And our second learning objective is you will be able to identify OT treatments that are part of the gold standard treatment algorithm for CRPS. So let's begin by looking at this journal article, and then we will bring on Megan Doyle to discuss how this could play out in your practice. The article that we are reviewing today is called Complex Regional Pain Syndrome, Practical Diagnostic and Treatment Guidelines, 5th edition. It comes to us from the Journal of Pain Medicine. It was published in 2022, and it is ranked 95th on our 2024 list of the 100 most influential OT journal articles. So what was the intent of this guideline? There is only modest, high-quality research in the area of CRPS treatment. But even without robust research, there remains a responsibility to treat these patients. Better evidence is certainly needed, but our patients cannot wait. These guidelines are an attempt to synthesize the best available evidence to aid in informed practice. So where do we stand on the diagnosis of CRPS? The label CRPS first appeared in 1994, making it a relatively new diagnosis. Criteria for CRPS have shifted several times since the 1990s, but the Budapest criteria remain a benchmark in defining the syndrome. And with a few clarifications, the criteria have been adopted by the International Association for the Study of Pain. So here's the general features of the condition, and I'll definitely link to the full criteria for you in the show notes. So CRPS is a syndrome characterized by a continuing, spontaneous or evoked regional pain that is seemingly disproportionate in time or degree to the usual course of any known trauma or lesion. The pain is regional and usually has a distal predominance of abnormal sensory, motor, pseudomotor, vasomotor, or trophic findings. Turning to standardizing the assessment of CRPS, the International Research Consortium for CRPS has recommended a core set of outcome measures for use in all CRPS clinical studies. And here are the ones from that list that seem most helpful to the OT clinician. 1, a suicide ideation assessment, the pain intensity numeric rating scale, the short form McGill pain questionnaire, the pain catastrophizing scale, the EQED-5L, the pain self-efficacy scale, and the patient global impression of change. I will link to these again in our show notes. So looking at treatment, the article highlights functional restoration through an interdisciplinary approach. Interdisciplinary or multidisciplinary pain management techniques emphasizing functional restoration are thought to be the most effective therapy for chronic pain. This approach may work by resetting altered central nervous processing and or normalizing the distal environment. Functional restoration is based on a steady progression from activation of pre-sensory motor cortices, i.e. visual motor imagery and tactile discrimination, to very gentle active movements to weight bearing. This progression is outlined in something called the Malibu Protocol, which is an algorithm of what this treatment can look like. It basically has these 4 boxes that talk about that progression that I just mentioned. I definitely encourage you to look at this actual protocol. I will link to it in the show notes, and we'll be talking about it a little bit more in the OT treatment section. So, fleshing out these interdisciplinary considerations for treatment, the article covers the role of each of the following disciplines for CRPS treatment. It covers occupational therapy, physical therapy, recreational therapy, vocational rehabilitation, pharmacotherapy, and psychological interventions. Each of these sections just offers this wealth of information, but for the sake of this review, I am going to zoom in on the occupational therapy section. But again, there are so many gems in the other section relevant to OT, so I encourage anyone who is treating this condition to read the guideline in full. So looking at occupational therapy treatment, the article states that OT professionals are ideal therapeutic leaders in the functional restoration process because they are trained in the biopsychosocial approach and are the primary practitioners in functional assessment and treatment. The OT evaluation of CRPS has remained consistent over the past few decades. It includes use of the extremity during ADL, coordination dexterity, skin temperature and vasomotor changes, and pain/sensation. However, the treatment approach for CRPS has shifted. I'm going to pull out the main takeaways from this section, and I'm going to break them into 4 stages, which kind of reflects that Malibu protocol that I mentioned above. I do want to highlight, though, that the article does not call these stages. I think this highlights that treatment isn't always linear, but for the sake of talking it through, I'm just going to call them stages 1 through 4. So looking at stage 1 of OT treatment, the theoretical underpinnings of treatments in this early stage are still under examination, but the use of these treatments is increasing and more definitive trials are needed. So in this stage 1 of OT treatment, there is graded motor imagery and visual motor feedback. The authors specifically point to the protocols outlined by McCabe for visual motor feedback, which I'll link to, and the protocol developed by Mosley for graded motor imagery, which I will also link to. The authors mentioned that mobile apps like the Recognize app are often used as a part of this graded motor imagery program. Okay, looking at stage 2 of occupational therapy treatment, following the visualization from stage 1, the authors highlight 3 things that can happen in stage 2. The first is initiation of gentle active movements. The second is a focus on minimizing edema. This is often done through specialized garments and manual edema mobilization. And third, they highlight normalizing sensation. This can be done through superficial or surface desensitization techniques. Heading into stage 3 of OT treatment, the OT can introduce a stress loading program to initiate active movement and compression of the affected joints. Looking specifically at stress loading incorporates 2 approaches: scrubbing and carrying. Scrubbing involves moving the affected joint back and forth while weight bearing through the extremity. Devices like the dystrophile can assist while maintaining consistent weight bearing. With carrying, progressively heavier loads are carried throughout the day whenever the client is standing or walking. And headed into stage 4, while general use of the affected extremity as tolerated is encouraged throughout the rehab process, stage 4 really focuses on increasing functional use of the extremity. And this can look like 1, movement therapies. At this stage, the patient should be better able to tolerate active range of motion, as well as coordination and dexterity tasks. Proprioceptive neuromuscular facilitation patterns are often well tolerated. This can also look like collaboration with a vocational counselor for return to work. Services like job site analysis, job-specific reconditioning, or work hardening, work capacity evaluation, transferable skills analysis, and a formal functional capacities evaluation should be considered. And as a final note in the OT section, the authors emphasize that it is very important for the therapist to upgrade, downgrade programs according to therapeutic response. There is so much more in this guideline, but I am going to skip right to the conclusion. As this 5th edition guideline demonstrates, there has been progress in managing CRPS, but more high-quality research is still needed. In each clinical situation, the specific risk, benefit, and expense of any intervention must be weighed carefully and continuously. This 53-page guideline was such a great read. There is so much in here to discuss. And I'm so thankful because I think I found the perfect person to talk about it with us. And that is Megan Doyle, MS, OTRL, TPS, FPS, CERT, AP, HPT. Megan graduated from Marquette University with a BS in exercise science and a psychology minor in 2010, and then obtained her Master of Science in Occupational Therapy from Indiana University in 2012. Throughout her career, she has worked in a multitude of settings focused on adult populations, including acute care, inpatient rehab, subacute, long-term care, worksite injury prevention, and outpatient, but has always felt drawn to mental and behavioral health, wellness, and pain management. She also has an extensive experience in working with the older adult population. Megan pursued the first TPS through Evidence in Motion in 2017, following this with the Fellowship of Pain Sciences in 2020. She is an active member of the American Occupational Therapy Association and is the current Idaho Occupational Therapy Association president. During her free time, she prioritizes going on adventures with her husband, son, and daughter, exploring all the recreational wonders Idaho has to offer. As a financial disclosure, Megan does teach other courses related to pain, in particular for Evidence in Motion and Inspire. So without further ado, I will patch Megan into this podcast. Welcome to the podcast, Megan. It's so great to have you.
Thank you so much for having me, Sarah. I've been a long-time listener, very excited to have this conversation.
Oh, I've been looking forward to this conversation for probably a year since I first saw your profile on LinkedIn and saw your name connected to that AOTA position statement on pain. I have just been thinking about CRPS all week and all morning and really anchoring back to this story probably from like 7 years ago where I was at a wedding and I sat next to a couple. One was a PT and she was with her husband who had CRPS. And we just spent hours talking about how this was impacting his life and all the things that they had tried. And they had hit this point where they felt like there was nothing else to try. And I just had such a sense of like, I think there's probably more, but I don't know what it is. I don't know who to refer them to. And I so wish I had a guideline like this, and version 3 of this guideline was probably out and I just didn't know about it. And I don't know, I'm so thankful for these kind of guidelines that give us a shared language, a really comprehensive view of like, we don't know everything, but there's a lot of stuff to try. There's other disciplines to bring in. So I'm excited to dive into all of that today. But first, I want to learn a little bit more about your backstory. Like, I think of you as a pain therapist. How did you get there? How did that initial interest in pain start?
Yeah, well, absolutely. So really earliest memories being in my occupational therapy program and being exposed to what holistic, just lifestyle management pain treatment could look like. I was able to do one of my level 2 field works at Ireland Army Hospital, which is at Fort Knox in Kentucky. And my husband was actually stationed there at the time, so I am an Army spouse. And the occupational therapy practitioners there in their mild traumatic brain injury outpatient clinic, so basically post-concussion, really took a holistic view working with those soldiers, not only on pain with their post-concussion headache pain, but stress, sleep, cognition, we were able to incorporate things like biofeedback or autogenic retraining, which is something that gets discussed in the article, and really thinking about the psychosocial pieces and looking at this comprehensively and holistically. So that really got that started for me. But also what drew me to occupational therapy is our background in mental and behavioral health and that all over holism and lifestyle. I myself am very open about my mental health journey, had a lot of difficulties growing up, and that really also drew me to the profession, really recognizing that from that humanistic perspective, had my own issues with headaches and sleep when I was a child. So just bringing in some of those skills and coping skills and strategies and seeing, wow, this is within our scope and this can be applied. And another piece of the journey is that I have worked in almost every single practice setting. I have worked in acute care in hospitals, inpatient, rehab, post-acute care, skilled nursing, long-term care. Pain is always there. And pain seems to be this thing that impacts every single part of a person. And now best practice is helping us understand that everything therefore then influences pain. And really feeling like that focus, that full breadth of holism is so integral to our practice of occupational therapy. Also, the fact that there's always the emphasis on psychosocial, which I love, and then also this focus on self-management. So all of those different things, I was already kind of there. And then really, truly what kind of drew me over the line to, okay, now I am this, pain OT, is about 2016, 2017. I was practicing in a different outpatient clinic with some great physical therapy colleagues, and they both were going through what is called the therapeutic pain specialist certification. And they started talking to me and they said, oh yeah, we're learning about pain. It's all about the biopsychosocial model. I thought, wait a minute, that is what occupational therapy is. That is what we as OT practitioners do. Let me take a look at this. And I decided to look at it and went through this certification myself. I fell head over heels in love. I thought, wow, my love of OT, the skill set that drew me to the profession, this is what I was made to do. I was made to work with people that are having pain. And I say pain, not just chronic pain, because I've also had the experiences in working again with individuals post, more recent acute pain and addressing that from the biopsychosocial model. At this point, really just also recognizing and going on to complete a full fellowship program and helping those that seem to be the most vulnerable and those without hope. Time and time again, meeting individuals that feel as though their pain just completely has robbed them of their quality of life, of their identities, of any facet of what they want to be. And those are the people that I want to be working with. And so it's really come full circle. And now I just can't imagine doing anything else on a day-to-day basis.
I have so many thoughts swimming in my head. I'm just coming off of a pelvic health podcast and hear so much of what you're saying echoed is what our pelvic health colleagues are looking at, this biopsychosocial approach, working with people in their vulnerability, coming in a lot of times when people don't have hope. And now I'm syncing together a lot of our pelvic health colleagues are working with pain, and that you're right, it's just underneath all of our practice areas is this management of pain. And it feels like as OTs, we get a lot of the tools that we need to work with pain. And I'm curious what the next layer will look like in our education of, I feel like there's another layer of education that we could all use around pain. And it just makes me excited for where we're going to go with that. Thinking of your story, I know that you're now working in outpatient, program manager at an outpatient chronic pain clinic. How did you get there? How did this interest become a full-time job?
Yeah, absolutely. So really coming into my current health system, and actually my first role here was in our acute inpatient rehab. I had really wanted to get back to outpatient, but that was what they had at the time, and I wanted to work for my current health system. and really discovered this need for helping any of, the individuals I was working with pain. And so seeing a lot of post-surgical neurological populations with really complex pain, starting to become the person that was the go-to, and working not only with clients one-on-one, but starting to have a passion for education, which is always there. I'm the daughter of two former middle school teachers. I always joke I got the double dose of the teaching gene and absolutely love education. And being able to have a role within that initial setting to coordinate with my therapy team. So really having that interdisciplinary perspective, all of us trying to speak the same language around someone's pain. And then I actually was able to go into a full fellowship program. And through that fellowship program, focused on a scholarly project where I worked very closely with our nursing staff, providing education around pain neuroscience or our new understanding or way to explain the neurophysiology of pain to anybody, and working with staff on this just all over holism and treating pain from that biopsychosocial model, especially promoting non-pharmacological options. And during that time, hearing about this opportunity for, my leadership saying, wow, here is somebody who is so passionate about this. We really do want to have an outpatient program. We really want to start to get this more out to the community. And I joke that I have many, many hats I wear. Now I have this new program manager hat, but my biggest hat with the brim on the bottom says OT. So the OT is always facing outward and layering more of the hats on top. So really going through the fellowship program that I did is what got me the skill set and really opened the door. They saw, okay, here is somebody who has this training, has this interest, is a leader, and to now be put in a place in this program that just started at the beginning of 2023. I primarily provide one-on-one services. I am our main occupational therapist providing services. It is mostly for individuals that have different types of chronic or persistent pain conditions. But also I do see folks that are having just really significant difficulty with their pain, more complex neuropathic conditions. CRPS, which obviously we're going to talk about today, is certainly have clients with that diagnosis. And on top of that, I have a role of triaging referrals, determining if somebody would benefit from not just seeing me. We actually just recently hired our dedicated physical therapist that's going to work alongside me so we can have that shared continuum. I also coordinate with other practitioners that might already be seeing someone and feel like a person needs that benefit of that one-on-one with me. And then really helping to provide recommendations for other services and continuum of care, helping to find referrals in the community for behavioral and mental health counselors. A lot of times, trauma counseling is really best practice for individuals. And we're really trying to build an in-house team. We do want to have a dedicated in-house mental behavioral health provider, whether that's a pain psychologist or a counselor, and to have a medical provider champion as well in-house. And really beyond that, having these opportunities to create education for the system, really being seen as Megan's our pain person in my health system and in the community, and trying to teach and educate other practitioners. Because I often say it's not about just me as this one individual practitioner. It is about truly training, changing the language, changing the understanding, and being able to have an elevated role within my health system. So I'm super excited. I feel like I'm in a great place with leadership, and I just see this continuing and for me to go on, these next stages of the journey.
I love hearing about this program. I have to ask, how big is your health system? I live in a town of 5,000, and I'm like, even at our small hospital, I could see this being a full-time role. Like, I know how much need there is, especially if you're thinking outpatient and consulting with our acute care. Do you think that's true? Like, what size of health system do you need to have a role like yours, I guess, is what I'm asking.
I think it could be any size. My health system is very large. We are the largest in my state and have multiple hospitals. So just starting out locally where I'm at, but I do get outreach from across the system. I'll get therapists that will reach out to me and say, hey, I'm working with this person. Could you take a look at their chart? I really think they would benefit from your expertise and working with them one-on-one. Or I've gotten outreach from our health system to present at in-house conferences, trying to educate the system that way. I just think that there's so much room and growth. But if somebody's interested in this, this is a role that any health system needs someone to be in, to be that holistic pain champion and to be a voice for that.
Yeah. I want to turn us to CRPS. And before we talk about the article specifically, I want to access your teaching side given to you by your middle school teacher parents. Tell me, when I'm reading about the mechanisms of CRPS, it's pretty complex. What do we as OTs need to know about the mechanisms of CRPS to help guide our treatment, and that we would also be wanting to communicate onto our clients?
I was going to say, so what we need to understand, this is where I was taught throughout my pain training about the tip of the iceberg metaphor, so that we as clinicians, to our best knowledge, should have that underlying, for thinking about the iceberg, and there's 90% is underwater and 10% is above water, talking about that 90%. And even so, recognizing I want to help the average practitioner understand some of these mechanisms. So we are going to go back to neurophysiology, certainly how we learned in our schooling. And I tried to pull out and to talk about some of the basics. So our best understanding with mechanisms for CRPS is that we need to understand we do have that peripheral nervous system, so our network of nerves, that connect to the spinal cord, and then up to our central nervous system, spinal cord, and brain. But we also are learning how much our nervous system and nerves have this bidirectional relationship. So the thought is that we could have someone, and they are still trying to find more specific risk factors. The article does a great job of recognizing that we still cannot say with certainty all the different risk factors. But best of our knowledge, we could have someone have what seemingly is a minor type of injury. A distal radius fracture is a great one to look at. And it might be that there is just so much initial inflammation, and at the periphery, we could have more of these inflammatory pieces with chemicals like cytokines, and having our danger signals, or nociceptors, we want to describe them as danger signals to our clients, sending all of this increased information and this inflammation at that spinal cord level. We do have our C fibers, which are those fast and furious kind of danger fibers. And we also have our light touch fibers, A beta fibers as well. And when those come into the dorsal horn at the spinal cord, we can have this ongoing barrage of this activity over time that can really start to change things from that periphery at that spinal cord level and start to change the gating of that nerve information. Also understanding that nerves fire both ways. And so nerves do fire impulses up towards the spinal cord into the brain. But also when we're talking about CRPS and seeing vasodilation, edema, heat, those nerves will fire down into that limb as well and really start that process. So we'll have that inflammatory response. We can have this concept of neurogenic inflammation where the nervous system itself is creating that and opening up things. And that's where you start to really see more of that vasodilation and heat and things like that. Understanding that pain is all about protection and this output. So having this nervous system over response be very ramped up. We can also have at that spinal cord level, secondary nociceptive neurons get really sensitized and send all of a sudden, again, all this information up to the brain. The brain is just getting so much information. It is feeling as though with that decreased gating that it has to keep everything elevated. It's not going to send down signals to downregulate with this decreased gating at the spinal cord. We can see increased sympathetic nervous system activity, Also understanding the role of adrenaline and catecholamines, other stress chemicals. That comes into understanding other mechanisms that can keep this elevated as well with ongoing stress and having that all be influenced with that sympathetic nervous system response. And again, with this upregulation from the brain and this decreased gating essentially from the periphery up to the central nervous system, this is where we start to see things like allodynia or light touch now being interpreted as being painful. We see hyperalgesia, things that normally wouldn't cause that much pain, like a pinprick, now are incredibly sensitive, incredibly painful. And so understanding there are those pieces at the spinal cord level or from the periphery with the nerves involved with that limb that had the inciting injury or onset. And then also we see what's referred to as maladaptive neuroplasticity. So we can see changes at that spinal cord. We can also see changes neuroplastically in different brain regions. And so this is where we start to understand pain involves multiple brain regions. There is not one brain region. We see more connectivity with the limbic system and especially our motor cortex and our somatosensory cortex. And that's where we're starting to understand some of these pieces and the whys behind some of the treatment that we're going to talk a little bit more about today. It's recommended in the article. But essentially, clinicians need to understand that what can happen is that the way the body part or limb in the brain is represented in that motor or somatosensory cortex is altered. We can have smudging. We can actually have that limb seem bigger. We can have disparities in laterality or understanding left versus right. So we see these different neuroplastic changes that I think clinicians are maybe sometimes more familiar in neurological populations like post-stroke, that actually now we're understanding play out in the brain and can elevate this threat perception, keep the output of that nervous system, keeping that dialed up and ramped up with pain.
I love hearing you talk because it lights up all kinds of parts of my OT brain. Some things I have to dig way back into the past to pull forward, but I see just the foundational knowledge that OTs have that lends itself to pain therapy. But I have to ask, when you are talking to clients, is this the language that you're using? How are you talking about this when you're educating them? Are you bringing out charts? Are you handing them anatomy books? What's the language that connects with people?
I was going to say, so we do need to talk about the language, and this is where pain neuroscience education or pain science education, pain neurophysiology education, there's a variety of terms, but we do need to be able to explain this in really easy to understand terms, and that can involve using some metaphors and stories. I do use a lot of visuals, and that is really highly recommended, and I have some great handouts I'll use as well. But really, when I will take everything we just talked about on a clinician level and talk about it more in terms for that person in front of me, I'll always start out explaining that pain always involves the brain and the nervous system, and that it's really this output with this perception of threat. So helping them understand that our nerves and our nervous system, which is 45 miles long of interconnected nerves, they've measured it, it's unbelievable, acts like this living, breathing alarm system. And we can have different things cause that nervous system to become more sensitive. And, when that initial injury or event occurred, an alarm got set off, but now that alarm system is having a hard time to be able to turn back off. And that alarm system has become very, very sensitive. And recognizing that we can have sensitivity, and that explains with the sensitive to touch, sensitivity to movement, explaining with that inflammation that everything is ramped up. That's why you're experiencing heat and swelling. And we're really seeing this overprotective response. And then talking about fight or flight and saying, we can have understandably this increased response, this feeling of fight or flight with this going on. This is quite a scary thing. And so we can actually have more stress chemicals flowing, and that can cause that nervous system to also stay sensitive. And also what I'll do is I will actually show images of the homunculus in the brain. So I love to pull up a homunculus image showing the somatosensory homunculus with the different body parts and explaining that and saying, we have maps of all of our body parts in the brain. And when we're able to move normally and we're not experiencing this, then all of those maps stay crisp and nice and sharp. But in something like this, when that sensitivity's changed, the brain may be seeing this body part as something that it needs to protect you from, and that threat is really elevated. So we need to look at how your brain also sees this body part in order to start to decrease this elevated threat that's going on, to get it to want to calm back down. And assessing and addressing those different pieces, and really also talking about that holism, that, there's other ways to help that nervous system calm back down. And we want to help retrain that sensitive alarm system in order to start to get that to calm back down. So a lot of that threat and protection response and sensitivity language with that alarm system is a really tried and true way to talk about this. And I have found that clients really do respond and understand that.
Mm-hmm. Yeah, and it feels like there's a general more education out there just like about the stress response, and people have foundations to build on in that. Where do you get your handouts? Do you make them, or can I go pick them up somewhere? I want to do what you're doing.
So I do have quite a few that I've gotten through my training, but there are some really nice free available ones. A great platform to get some nice clinician handouts from is Curable. That is actually a platform that was made for people with persistent pain or chronic pain by people with persistent or chronic pain. They have a really great diagram that shows all of these different stress components and chronic stress and pain. And that's a really nice way to be able to look at these different pieces. Something we are understanding, and the article does a nice job of talking about this, is that it very well may be, and the evidence is not showing, that people with more stress conditions, mental health, depression, anxiety, are at greater risk for developing CRPS. But clinically, there are these pieces where if that stress is ongoing after the fact, that could be, unfortunately, factors that could perpetuate something like CRPS. So showing that diagram is really helpful. I do like to draw out and sketch the sensitive alarm and we'll kind of draw that, and we'll write out, what are the different things that are maybe contributing to things staying really sensitive. And then also, like I shared, going online and showing those images of the homunculus has been really helpful as well.
Yeah. Turning to this 55-page guideline, I am so curious to hear your impressions of it. When I was writing the overview of it, this is the first overview I've ever written where I was like, I did not do service to this article because so much of it felt like it applied to OT. Like all 55 pages felt like it applied to OT. What were your takeaways from it?
I couldn't agree more. I annotated the heck out of this article. Yeah,
it's just a giant underline for me.
Yeah, but it is. I was very impressed. It is very comprehensive. And I appreciated so much the author's focus on the biological, psychological, and social. They really, truly did that a great service. It is important for OT practitioners to understand the medications and the interventions and the mechanisms, because this is now what I do full time. Yes, I'm not a prescribing provider, but I need to be able to speak to the mechanisms behind those. I need to be able to understand why somebody maybe was recommended certain interventions or medications. And I always encourage them to ask those questions too, but at a bare minimum, just being able to understand that. I do understand that maybe more the average practitioner that isn't doing that all the time may not need to know that quite as in depth as I do, but this article was very helpful with that. On top of that, really emphasizing throughout that interdisciplinary, it was so beautiful because they did a nice job defining and showing interdisciplinary. So really having that core, that person at the center, that client at the center, and having that shared language and everybody interwoven with that, versus multidisciplinary is still a best practice, but that still leaves us practicing a little bit more in silos and recognizing that something as complex as CRPS really does demand interdisciplinary or at a minimum multidisciplinary as much as possible. Also couldn't appreciate enough with the article. They were so honest with their balance of evidence, but very humanistic. I loved the quote, "In the humanitarian spirit of treating our often desperate patients with this rare syndrome." It is refreshing to read an article with such depth that you could tell these are real people who really care about this writing. It was great. And acknowledging the patients as well, that this is about them. Also, other pieces that were so important, talking about different roles. They really inferred that psychological and assessment and intervention early would be better despite the different evidence and guidelines. There was the guideline of, if some of these other pieces aren't occurring, then consider psychological intervention. I appreciated that the authors really emphasized, really, actually, we would recommend based on this, based on clinical experience, that we need to look at that. And I think that's such a role for occupational therapy, and that really stuck out to me. Also emphasizing the role of education. They didn't say pain neuroscience education by name, but just recognizing that that was somewhat what they were inferring, and then also highlighting the need to acknowledge social and family influence from that social piece of the biopsychosocial model. And also there was limitations, of course, with the research and articles they used in the occupational therapy section versus other roles. And that's, definitely something that I know we plan to discuss later.
Mm-hmm. I want to get into what you, Megan Doyle, would do walking in to see a CRPS patient with this treatment guideline in the background of our minds. And start with assessment. The article mentioned a couple specific assessments, some that I recognized that have come up other times. They talk specifically about the CRPS severity score, which I don't think is widely available. I don't know, what assessments do you gravitate towards? And was there alignment at all with this treatment guideline?
There was quite a bit of alignment. Again, it was very comprehensive. I think that there are some assessments that are also just a little bit more accessible for the everyday clinician or OT practitioner. So they did mention the pain self-efficacy questionnaire. That is something I really enjoy using, looking at those 10 different questions that it has. Really focuses on what are individuals able to do despite the pain. And that is such a huge piece of this. Anybody with pain or any persistent pain conditions, but self-efficacy gets spoken to a lot for CRPS. I agree completely with having a formal suicide ideation question. I am always on the lookout, and we do thankfully in our health system have an emphasis and a formal process for that. We need to appreciate with something like this, people may be just in a place where they don't know what else to do. And so I did want to highlight that. I think that's incredibly important. We should always be asking that of our clients. I would also agree with their recommendation, and I incorporate the pain catastrophizing scale. It's my understanding that soon the word catastrophizing may be removed from the scale, and that would probably be of benefit. But I've talked to my clients about it, and they've said actually, they appreciate the language, and that is a score that I see change a lot and has been shown in the literature to make a difference. So for what it's worth, there is quite a bit of efficacy with the pain catastrophizing scale. I would add a central sensitization inventory. This is a much newer questionnaire. OT practitioners can freely download and use it. It has the citation on the scale. And what it does is it can give us a bit of a clue of, this did start out as CRPS, but is that person's nervous system now becoming that much more sensitized? Are there becoming more widespread symptoms that would be indicative of that? And it's a helpful screen. And then I would also add the Canadian Occupational Performance Measure. They talk in the article a bit about goal setting, but really having this occupation-based focus and having somebody being able to speak to what are the things that they really want to get back to doing? What do they want to see change? And having that goal setting and that efficacy piece. And I think that's where we as OT practitioners could bring that in so beautifully. Other pieces would be that they speak in the OT section about graded motor imagery and limb laterality. So I often will do a laterality assessment. I do have the hard copy cards. So there are body part image cards out there. They do mention by name the Recognize app, which is trademarked. I do like that, I have to admit, because it does the math for you. So, let's say I'm treating someone who has been diagnosed with CRPS of the hand. I actually might go farther away from the hand and do a laterality assessment of the shoulder, because the shoulder may be less threatening for the brain because it's further away from the hand. Vice versa for maybe a knee for feet, especially if they have a lot of allodynia and things are really, really ramped up and sensitive. Also, maybe not right away, depending on how sensitive the limb area is, it would be appropriate to do a 2-point or 1-point discrimination assessment. And also there is pain pressure algometry to get pain pressure thresholds, but not always priorities right then, because the biggest thing at that first visit is providing validation for this person, providing education. A lot of times they will say, well, I kind of understand what CRPS is, but nobody's really been able to explain this to me very well. So providing that education piece is so huge, because that really can help reduce that threat perception, help that person start to understand, hey, there is hope here. We are going to help you find a way. We're going to help you find a way to make your life work for you, to get this to calm down, to go more into the background. And so some of those other assessments, I want to do those very early on, but trying to have some of these other priorities in that initial evaluation and really setting that stage for that person to be their best expert on themselves, and for us to start to have some of that meaning making, setting those good occupation-based goals for them.
I'm loving hearing all this because it's so concrete. It gives such a good starting point. I always think of myself working in a small town where maybe I see someone with CRPS every 2 years. But this gives me such, just a concrete place to start. Headed into treatment, the article spent about 2 pages on OT treatment. I'm so curious what you thought of this section. It was really focused on graded motor imagery and the visual motor feedback. Are those the gold standards that you think of for OT? I don't know. A lot of those protocols came to us in like the 80s. Is that still the gold standard for us? Yeah. And I'm just curious what you thought of like the general algorithm that they put forth too.
Yeah. So there definitely are some pieces there. And I will share that interventions like graded motor imagery or the motor visual feedback are supported by our current AOTA guidelines, occupational therapy's role in pain management. And doing that as an assessment to really start to look at those neuroplastic components, especially within the central nervous system and the brain. So I would say it would be appropriate for OT practitioners to do a laterality assessment and to go along the continuum. There are multiple stages. So to look at right-left discrimination. What's interesting is that, let's say somebody scores within norms, and there are norms for all the different body areas. But I have had clients share, they'll look at the pictures and they'll go, whoa, I can't imagine my body part doing that movement. That looks painful to me. Or they'll actually be looking at the images and will experience a flare-up of symptoms in that limb. That tells us, okay, wow, there's something really there. There is this elevated threat perception. We do need to do some graded exposure of looking at these images, working on making this look safer to that person. And then there's a continuum of, once that is not causing those symptoms like that, or they're able to look at images of other people's limbs, then to start to do more internal, so visualization of their own body parts, looking at that as safe, and then doing the feedback of looking at the image and reflecting it and thinking about their own, starting to think about movement. Now, the thing that I feel like is most important is working towards occupation-based. That was a piece that was missing. So insert that into all these pieces.
Yes.
So occupation-based thinking, wow, what are the occupations they want to get back to doing? visualizing that limb participating in that, understanding the emotional and psychological pieces with that. There is this process of, am I going to get back to actually being able to do that? And so just being ready for that and aware. This is where integrating other pieces from that overall calming that nervous system perspective that I'll get to here in a minute from the other pieces of the article, but more parts that were from the OT section, going along that continuum, eventually working towards mirror, but there is this continuum. Also, they do talk a lot about addressing the edema, sensory, and loading. And that has been around for quite some time. One thing that we do have that's newer language is not sensory desensitization, but sensory discrimination. So having the brain start to be quizzed and essentially tell the difference between different textures, having textures be placed on the unaffected side. The brain gets that sensory input, that nociceptive input of, ooh, okay, that's what that feels like. Okay, now let's try moving that over here. But that's all done in more of a stepwise fashion. So you'd really want to start with the premotor cortex with the laterality retraining, work towards that, do more of this internal visualization, which is referred to as explicit motor imagery, start to address these sensory discrimination pieces and start to change the relationship with how those textures and different sensations are now not interpreted as being as dangerous and being more of these types of textures that are actually safe and not painful, and then working towards the mirror, but always working towards that occupation-based piece with all of those. So incorporating sensory pieces into occupation, making sure when we're eventually progressing to any type of mirror feedback, we're progressing to function. For instance, if you were to do mirror box therapy with somebody with their hand, you would eventually want to work towards functional movements and activities with that hand, whether that would be their dominant hand, handwriting, picking up feeding utensils, things that have meaning for them, of course, would be the hallmarks with neuroplasticity. So some of the pieces from the OT part, but they don't specifically talk about occupation-based when it comes to incorporating the loading, the carrying. So thinking about how could you have them carry and facilitate objects or loading in their occupation. So loading a lower limb, not just with walking, but, having them stand and wash dishes or engage in a work-related task or a fun leisure hobby task, which brings me to talking about the other roles that were talked about. Because as I went through, it was, oh, wow. In physical therapy section, they talk about pacing. They talk about graded activity with intolerance threshold, sensory motor, all things that we know as OT practitioners within our scope well and can incorporate, again, in an occupation-based manner with somebody with CRPS. Graded exposure and incorporating this reduction of fear of these different activities within this tolerance threshold for that limb that's experiencing this really promotes that self-efficacy and really starts to decrease this overall threat perception and starts to really promote that overall improvement. And then also from the recreational therapy, emphasis on leisure and hobby participation. We would, of course, as OT practitioners, want to do that. That's well within our scope as well. Return to work with vocational rehab, working on those great client factors. I think a great place for OT practitioners to think through is our current occupational therapy OPTF4 practice framework. All of those different factors would play out for somebody that has CRPS. And also the education piece, making sure we're explaining all the mechanisms in a patient and a client-friendly manner, emphasizing the social components. We know social participation is its own area of occupation. And then the psychological intervention section. I love utilizing relaxation techniques, autogenic retraining, cognitive behavioral therapy, acceptance and commitment therapy gets spoken about. That is so in line with mindfulness and value-based practice. There's so much there that is in alignment with our occupational therapy scope. Focusing on coping skills, asking and addressing sleep, and emphasizing self-management. So to kind of round that all out, I think that an occupational therapy practitioner should feel confident that if they were to go through this article, they could take away all the pieces that are listed in these other roles or disciplines and have confidence that's within their scope to incorporate.
Do you have a general arc of a session that you like to follow? Like, I start with relaxation, then we do something challenging, and we end with relaxation. Like, how do you think about, just like the timing of things in one treatment session? Do you have a set arc you usually do?
It's really hyper-personalized, as I'm sure you can appreciate. Really meeting that person where they are, let's say they come in and they say, wow, I really had a flare up of my symptoms since last time I saw you. So doing some good detective work together and it'll come out, I really tried to do a lot more with my hand, and I know that I should be trying to do that, but things got really sensitive and I'm having a lot of stress at home. And so starting to ask those questions and talk about that, asking about sleep. They may say then, I had a really hard time sleeping, and just meeting them where they are with that. So there can be that relaxation component. I will say using breath work, breathing techniques for down regulation is really great, because that can be something that can be incorporated in anything. Integrating the mindfulness pieces and helping with that education piece, helping somebody recognize, oh, wow, things got flared up, not because there was anything I re-injured, but because things are still really sensitive. And I did a little bit more with this limb or my hand that is experiencing this. And that was a good thing. I was trying to do this. And so finding those ways to calm that back down, that could incorporate the relaxation. Depending on where we're at in that graded motor imagery continuum, it might be appropriate to do some of the picture images with laterality. Maybe if they've progressed a little further, we could go back to more of the visualization of that limb calming down, incorporating the breath work with that. It might be appropriate to go back to doing more of the sensory pieces. So having them have their different sensory textures that they found are actually more calming overall and helping with that sensory discrimination, really emphasizing always that self-management and then problem solving together. How could we practice then in an occupation-based setting in that visit? What were part of the things that you were doing? Let's go to a space where we can replicate that as best as possible, simulate those activities that you were doing. And then in that moment, try to recognize, okay, I'm listening to my hand. It's starting to get a little more sensitive. The alarm bells are going off a little bit. That's okay. Would that be an appropriate time for self-monitoring, self-regulation? Let's back off a little bit. Let's incorporate some of our breath work. Let's focus on some different sensory down regulation strategies. So there's so many pieces there. And then also, too, if they mentioned about sleep, making sure that we're doing some great sleep performance education and making some recommendations. So trying to incorporate the self-management, trying to incorporate for somebody with CRPS, perhaps if we're doing the graded motor imagery continuum, where are they at with that? And then trying to emphasize overall the coping skills, the strategies, making sure that they are feeling as though they're in control and can find those ways to dial that sensitivity down as we go forward, while also anticipating that there are going to be flare-ups and recognizing what was contributory, that doesn't mean that we're not making that forward progress, but helping that person be able to recognize that and be able to decrease that for themselves.
I could listen to your clinician brain all day. I love thinking about that one-on-one time with the patient. I'd be remiss not to tap into your the coordinator side of your brain too. It's so clear that interdisciplinary management is the way to go for pain. But I don't know, do 1% of us actually get to practice in an interdisciplinary setting? That is not the standard here in the US or around the world. What have you learned about coordinating care in our imperfect systems? What are some practical tips for us to simulate close coordination of care, even though our systems aren't perfect?
Yeah, absolutely. Because it's really challenging sometimes and really tricky. So knowing your community resources and being willing to reach out to them if needed and ask for help, ask for collaboration. I've tried really hard to start to recognize who are different counselors in the community who really is starting to understand this overall model with pain. certainly physical therapists, rec therapists, vocational rehab. So starting to recognize from this article, here are these different components and who could be that person in community. Make those relationships. I have the benefit of people starting to hear a bit about me and what I'm doing. And so also it can go both ways, where if you have an interest, you can reach out and say, this is my understanding of this. This is, kind of the background and education of what I'm seeing. What's your understanding? And if you can find those champions in the community, ask for that collaboration. And that could mean starting out with an email if possible. I know we're all busy and it's hard to find time, but to the best of for our clients, truly calling these practitioners, even connecting in clinic. I have the benefit of I've had other practitioners want to come in and either observe a session or collaborate with me for that client. That's clearly not always going to happen. So whether it's connecting, using technology, using email, using phone, but trying to know those resources in the community and be able to connect and collaborate and educate together, and trying to speak the same language with that client and those other involved practitioners above all else. And that's where having that education piece can really come in, and just recognizing the need to have that shared common language so that everyone's on the same page. Feeling comfortable reaching out to providers in the community, feeling comfortable to reach out to referral sources, having those conversations. I think sometimes we can get, understandably, as OT practitioners, am I on par with, this physician that diagnosed this person and, is sending them to me? Have that shared camaraderie as colleagues, do what we feel like we need to do for best practice for our clients and to their benefit. And I just can't say that enough. I love so much that's what's emphasized in our practice framework is focus on agency for our clients and self-autonomy. And so we can help facilitate that when we're dealing with a condition as complex as CRPS.
I want to end by zooming out on pain. There are so many unmet needs when it comes to treating pain around our globe. There are so many things that we as OTs can do. Where do we need to head in terms of pain management to even come close to meeting this global need? Like, what needs to change? It's not working. What do we need to do differently?
Yeah, that is a massive, massive question. I feel, though, the best possible place I could start, and I'm going to quote someone who's near and dear to my heart, Colleen Lowe, who went through my fellowship training with me and is also an instructor, as I am as well, for different pain courses. Her quote is, "We need to de-educate to re-educate." And so what I share with people that I'm working with is everything that we're understanding now is so new. This whole holistic lens of all of this, we've really lived in this rudimentary, very rigid biomedical model for a long time, especially here in the West. That gets spoken about a lot here in the United States and more Western part of the world. And so we need to do a bit of myth busting. We need to start to recognize that the way that pain works is not, we have this injury and that causes pain from the pain tissues. We need to recognize the mental health pieces, again, from this biopsychosocial model. We need to recognize people are suffering and having difficulty with coping. They're having difficulty with getting answers. They're having difficulty with recognizing that they're going to be okay. So looking at this globally, it is trying to look at this from that big holistic population health lens. And there are really great outreaches and research that's started to be done. Another piece to this from this myth-busting perspective is teaching children. So teaching children in schools, teaching their parents. How can we start to learn our new understanding of how pain works, to start to look at this holistically, teach those non-pharmacological coping skills, strategies. And our culture, a lot of times, well-meaning, wants to understandably have a quick fix. And so recognizing that as well, recognizing as a culture and society that as humans, we have pain and have pain for a reason. That is now very different from this element of suffering. That is very different. So we need to provide that validation. But so much looking at education from a very young age, and that's really a big place to start. So it's exciting to know that there's this research coming out about teaching about pain and pain neuroscience in middle schools and elementary schools and working with their parents. Other countries have done an incredible job of having PSA campaigns or public service announcement campaigns. In Australia, they actually had billboards trying to normalize back pain. So there are other countries that are really trying to make this a big public issue, as it should be, and having open conversations about it. And then, as I mentioned too, recognizing the role of trauma, really highlighting an elevated trauma-informed care, recognizing childhood-related trauma that then goes on with adult, recognizing how in this new understanding of pain and pain neurophysiology, with the stress neurophysiology and trauma, there's so many overlays there. And to get that out into the light and to keep having these conversations about our overall psychosocial and mental health.
Yeah, it just feels like if we as OT practitioners can collectively up our game in this area, there's so much we can do. There's so many ways we can help. And we have, as I hear you talking today, I'm like, we have all those foundations to really position us as leaders here. We've talked about so many things today. What's the most important takeaway that you want people to leave this episode with?
I really want OT practitioners, because I really recognize that pain can seem so, and it is so complex, and it can seem, quite frankly, sometimes kind of scary. This person I'm working with is going through all this pain. This seems so complex. Where to start? I want for OT practitioners to embrace the holism of our full scope of practice, to recognize that we really do have these skills and the scope. That's why this article was so amazing. If we were to look through it and recognize, wow, all these pieces here are really within our scope. We do have these skills to address not only a condition like complex regional pain syndrome, not only other types of more persistent or chronic pain conditions, but truly all pain. When someone is going through that pain experience, to recognize the psychological, to recognize the social, to recognize, yes, there are the biological pieces and we need to address that, but we need to start from an occupation base. We need to promote coping. We need to promote self-management skills. We need to look at that person in front of us and look at this very big and broad and holistically. So that's always my call to OT practitioners. We are so well poised to be able to address that person's pain comprehensively. And I want to see us own that. I want to see us own that and be proud of that and recognize that we do have that skill set. Our practice framework tells us so. All of the parts of the practice framework are there. AOTA's, OT's role in pain management, it's all there. And so I want people to have that confidence that they really do have the ability to address this comprehensively.
Megan, I'm so thankful that you chose this as your career path, that you are a leading voice on this. Thank you to your middle school teacher parents who just made you a great teacher and leader for us. And thank you so much for the time today. It was so concrete. It was so helpful. And just thank you for the larger work that you're doing around this.
Well, I can't thank you enough for having me and having this incredible platform. Just really as a call out to my fellow OT practitioners. And, you all heard the passion of my voice, and this is everything to me. But I just am head over heels in love with our practice of occupational therapy and just really appreciated this opportunity.
Wow, you all, I just loved how concrete and actionable this course was. In the club, we will be linking to all of the assessments mentioned and all those other resources. On the podcast, over the past few episodes, we have been talking about the areas that OT really needs to mobilize on in the upcoming years. And this episode just convinced me that pain management is one of those areas. But as always, I really want to hear your thoughts. If you are a casual listener, we'd love a review from you. You can now review us on Google from our homepage, and we always appreciate your comments on our YouTube video. But the best place to really discuss the implications of all of this is in the OT Potential Club, and I will be watching for your comments in our forum. The OT Potential Club is also where you will go to earn a CEU certificate for your time today. To earn this certificate, what you are going to do next is either sign in or sign up for the OT Potential Club. And once you are in there, you can take a 5-question test. And when you pass, we will generate a certificate for your time today. Okay, I want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.